Morning. I'd like to thank for Xing for inviting me to speak at the workshop. My name is Scott Beach. I'm from the University of Pittsburgh. I come from a slightly different perspective than like what we've heard for most of the conference. I am not a clinician. I am a social psychologist by training. I've lots of training in research methodology, statistics. In graduate school, I had an interest in reactions to criminal victimization. So this notion of reactions to victimization has always been of interest. And then when I started my professional career, I work at a center with Richard Schultz, who does lots of work, one of the leaders in caregiver mental and physical health effects of caregiving. And we published several papers together, including showing that caregiving itself is a risk factor for mortality. That came out in the late 90s. So, and he's done a lot of work with Alzheimer's disease caregivers. And of course, the other thing, I also direct the survey research program at my center, so I run a survey lab. So the telephone survey work that we've heard about is of great interest to me, so therefore I have obviously interest in survey methodology, self-report methodology, assessment. I should say that I'm a little bit different. I'm back to maybe yesterday's presentations on some of the prevalence studies out in the community. That's kind of where most of my work is, though a more recent one we've looked at some stuff in assisted living. So what I want to do quickly is give a brief overview of some of my work. As I say, it's mostly community-based. I would say it's more sort of detection out in the community kind of work, not so much screening. But then I do want to have a couple of slides to sort of help generate some discussion where I think I provide sort of an overview of screening and detection in the elder abuse area. So let me start with a couple of the things that I've done. First one I want to talk about is this Frill study. Gail Williamson, University of Georgia, was the PI. This is a caregiver, care recipient dyadic analysis. We were looking at significant predictors of what we called at that time, this was 2005, potentially harmful caregiver behavior. It's basically psychological and physical abuse as measured by the modified conflict tactic scale. The sample size here, I don't have a lot of detail on my slides, but I'll do it now, was 265. And we got reports of psychological and physical abuse from both the caregiver and the care recipient. The data I report, the outcome was the care recipient's reports, though there are caregiver health report data in the model. So what we found, and this speaks, I think there's a lot of discussion about the different models and the caregiver stress model. I have this slide here, I want to make it clear. These were our significant predictors. So we found that, and this is care recipient reports of mainly psychological abuse. We found about a 25% rate. A lot of it was screaming, yelling, insulting, lower levels of physical abuse. So the level was fairly high, mostly psychological, but we found the more physically impaired the care recipient was. Spouse caregivers were much more likely to report this. Some of the sample were adult child caregivers. This was mainly a spouse phenomenon. But the last three things, the caregiver being in themselves, have lower cognitive status or more cognitive difficulties, the caregiver reporting more physical health problems, and the caregiver being at risk for clinical depression using the CESD cutoff. Those were the predictors of psychological and physical abuse. And I would not call those three things caregiver stress so much as poor caregiver health. So you have these situations where older adults are taking care of a spouse. You've got the sicker one and the sick one, kind of, in a way. So I think we need to think about that. So that was kind of how I got into the elder mistreatment area. And then, this is a long title to a paper that actually was published in a journal I don't think a lot of folks read here, but let me talk about this for a second. This was funded by NIA. Sid is over there. This was an R21. And what I looked at, you think about elder mistreatment and getting people to report that. In the survey methodology literature, we're very concerned about reporting on sensitive topics, right? How do you get people to report on sensitive topics? And this is certainly a sensitive topic. What you find in surveys, people underreport things like drug abuse, alcohol abuse, and everybody goes to church and votes. I'm not sure why that is when you do a survey. We've developed these methodologies. What this study did, it was a randomized experiment. We did 900 surveys in the Pittsburgh region. Random digit dialing was used to recruit. Half of them were assigned to an in-home interview, half to a telephone interview. And within those telephone and home, half were traditional interviewer administered, and the other half we used technology. On the phone side, interactive voice response, we switched them over to a system where a recorded voice was collecting the data and they punched in using a key phone. In the in-home, audio computer assisted Interviewing, basically you give the laptop to the elder and you offer them, they can wear headphones and the questions are read to them. It sort of creates a sense of privacy and isolation. The questions are read to them and they respond by themselves on the computer. So I was really wanting to look at both feasibility, will older adults use these technologies, and perhaps more importantly, if the answer is yes, does that affect our prevalence estimates? Do you get higher rates of reporting abuse when you take the interviewer away from the situation, make this more private? So that's basically what this study was about. And very quickly on feasibility, what we found was basically that older adults were able to use this technology. So in audio casing, one of the interesting things we found is about a quarter of them, a little over more than a quarter, didn't want the headphones. They said, just give me the computer, I'll read the responses. And that's okay. There's some data showing that the headphones themselves, the idea there was more for lower literacy populations. So in other words, about over 80% actually took the computer and answered the questions themselves. So I consider that fairly good. About 18% sort of said, no, just keep reading me the questions. And IVR, we also had pretty good, when we switched them over to this automated system, over 80% were able to do that. The main issue we had is the survey was done a few years ago. Actually, some of the older adults didn't have a touch-tone phone, so it was more like they couldn't do it, whereas with the computer, they wouldn't do it. So feasibility was basically pretty good. Older adults appear able and willing to use this kind of technology. So then we get to prevalence. So here are the sort of key findings, and this was a paper from 2010, Journal of Official Statistics. I don't think that's a night reading before bed or anything, but it's Statistics Sweden, lots of survey methodology stuff gets into. It kind of got into the survey methodology literature, but what we found was, this is for financial mistreatment, if you look at the prevalence rates, and we did it since they turned 60 and in the last 6 months, and we used, I'll do a mea culpa, our measurement on financial mistreatment is kind of weak. It's 4 items. We certainly, this was not a measurement development study. It was more of a kind of how you, it's a methodological study, how you ask the questions. But we used questions about, signing documents they didn't understand, suspecting that, having suspicions that someone was taking their money and so forth. So there were 4 items. I don't have them right in front of me. But what we found, an overall prevalence rate of 9.7% since turning 60, 3.5% in the last 6 months. But if you look at the highest prevalence rates we're using the audio Casey system. That's a significant difference. So the prevalence in the last 6 months was about 7.3% versus 2.5% when the interviewer asked the questions. Also interestingly, if you look at those bars, you really get better reporting in the in-home interview. The Cappy and the audio Casey are in the home. Most of them were in their home. There were a few that were done at our offices. Didn't seem to make much difference. But face-to-face interaction seems to result in higher reporting for older adults. The results were even more sort of dramatic when you looked at psychological mistreatment. These were, again, kind of conflict tactic scale type measures. Here you see, if you look at, say, the last 6 months, we got a 16.4% prevalence rate when we use this privacy-enhancing technique in the home versus 5% when the interviewer is asking the questions. And in this case, IVR actually did pretty good too. It doubled the prevalence rate. So I think just the point here, the take-home point, I mean, we've heard a lot about, and I realize why you do it, because telephone surveys are more cost-effective. You can go out, you do random digit dialing. It's easier to do. But we may want to consider that the prevalence rates we're getting from those phone surveys are even low. I mean, we might want to think that Ron's getting 10 or 11%. We've heard that figure many, many times. I mean, who knows? Maybe it's 20%. It depends on, and it all comes down to that issue of disclosure and privacy. So that was the sort of R21 study. Another piece of work, and I think Dr. Mouton referred to this earlier, from the same sample, another paper, we found very large differences, very large racial differences in reports of financial exploitation and psychological abuse. So you can see here, African Americans, say in the past 6 months, the prevalence was almost 13% versus only 2.4% from our non-Hispanic white sample. This collapses across the 4 technologies. There were not, these race differences basically showed up no matter which of the technologies. A little bit of variation, but basically it collapsed and controlled for that in this paper. This was published in the Gerontologist in 2010. And the results for financial abuse, or I'm sorry, for psychological abuse, not quite as dramatic, but you can also see significant differences there. So there seem to be The African American community. This survey was done around the Pittsburgh in Allegheny County, which includes Pittsburgh. Not sure if it, but I have seen some other results that sort of corroborate this. A couple of other recent collaborations very quickly. With Nick Castle, this is funded by NIJ, a examination of resident abuse in assisted living facilities. For this one, so this is the only one I've done, at least that I've been directly involved in, that looked at abuse in facilities. Assisted living is neglected. Lots of stuff in nursing homes, but we don't know much about what's going on in assisted living. So we used the approach, or Nick really led this, a mail survey of nurses' aides on the Pennsylvania Nurses' Aid Registry. And what he did actually, he asked them, it's not where they're currently working, but if they used to work in an assisted living facility, to try and reduce potential underreporting. So I thought that was kind of an interesting methodological twist. And he also did 4 types of measures. Did you observe it? Did you get a direct resident report? Did another person report? Or do you suspect? And we got pretty high levels of all the different types of abuse. I don't have the numbers. I think it was range. And he did it at the item level, so they range from 15 to 40%, depending on which of the 4. I do that a lot. People stay away from me in meetings. I like to wave my hands around. So fairly high levels of reported abuse from nurses' aides who used to work in an assisted living facility. The last sort of collaboration I want to mention, very recent, with Eileen Wigglesworth and Elizabeth Morrison at UCal Irvine. And this is going back to kind of a caregiving mode, looking at elder mistreatment in those caring for people with MS. And for this one, another kind of methodology, they had a list, a national list. NARCOMS provided a national list. They mailed out invitations for people to use an 800-number anonymous call-in methodology. And we got 206 people with MS to call in, completely anonymous. We were not allowed to get any information about who they were or where they were from. And we found, and this is reflective of some of the other data we've seen, over half of them reported some form of mistreatment since becoming disabled. And a lot of it, psychological again, but high levels of neglect, physical and sexual abuse. So those are some of the things that I've been doing. Now in terms of, that's good, 2 minutes. So in terms of kind of an overview, let me just show this slide. I think what we've been talking about, we've got different situations where we try and think about finding, detecting, screening for elder abuse. You've got community dwelling, cognitively intact, community dwelling, cognitively impaired, institutionalized. There are cognitively intact folks in institutions, we know that, and cognitively impaired. How do we go about screening and detecting elder abuse? We've heard talks that use a lot of these methodologies. I just want to flash these up as a discussion point. There's a lot up here, but when we think about going out into the community dwelling, cognitively intact, that's the work I do, the work that Ron does, Mark Lack's going out and basically trying to survey people. You can do that through direct victim surveys. You can do these random sample surveys like I did, like Ron does. You can do targeted disease surveys like the NARCOM survey. You can do direct, you can ask caregivers. Caregivers of Alzheimer's patients and other types will tell you about abuse. They do not consider it, as we've heard before at the conference, I don't think they consider it abuse. They're just kind of dealing and coping with a situation that's tough. Perpetrator surveys are kind of tough. I think when you go out randomly and just sort of ask people if they've ever done it, I don't think that's been very successful. The Sentinel approach that training folks to sort of detect people out, they tried that with that first national elder abuse incident study, found a very low prevalence rate. Healthcare screening, we've heard a lot about that. That's kind of a huge area. Social service providers. Laura Mosqueda is doing very interesting work on forensic detection, bruising. Mark talked about in a physician context, you can see that. And of course, we have the iceberg thing, the APS, the official reports. When we get to the cognitively impaired, it gets really tough. It's basically the same list without the direct sort of victim survey. So you kind of have to use these more indirect methods. And I wanted to, this issue of are people with cognitive impairment able to do surveys? The answer is yes and no. It depends what you're asking them, and it depends kind of what level. The first study I talked about with the Frill study included folks who had sort of mild to moderate cognitive impairment. We reran the model after we took out folks with a cutoff of higher cognitive impairment, and the results were not affected. So we didn't sort of seem to, it seemed that the folks with mild cognitive impairment were okay answering those kind of questions. When you get to the institutionalized, it gets even trickier. Now, if you have cognitively intact residents, you can go and ask them questions. Family surveys, which were kind of criticized yesterday, Staff surveys are big. The one we did, you can survey other residents. Video monitoring is kind of like on the horizon. I mean, this guy at Pitt that does this kind of work, where in public spaces they've got continuous video, and you can see lots of resident-to-resident aggression on those videos. Lots of issues with doing those kind of studies. Forensic analysis, and of course official reports. And again, you can have both staff-to-resident and resident-to-resident abuse, as we know. And finally, with the cognitively impaired, you basically the same kind of things without the direct resident surveys. And finally, oh, so that comes up. I just wanted to, I know I'm running out of time, I just want to throw a few things up on the screen. I think elder abuse from whose perspective? We have all kinds of different ways to do this. You ask the victim, the person directly, are you being, you don't say are you being abused, but you ask behavioral questions. Clinicians, proxy informants, if a person is cognitively intact, should we always get their perspective? I mean, why, if someone's cognitively intact, why use a physician's diagnosis? I mean, it's the issue of autonomy, just something to think about. Which screening measurement or tool to use? We've seen many options. I think easy is looking pretty good. I'm interested in interviews versus self-administered. What kind of technology do you use? The setting, I think, is very important. Are they answering these questions in their own home, in a PCP office, in a dentist's office, Terry Fulmer's work, at a waiting room, in an ER? I mean, think about answering questions about abuse in a waiting room or an ER context. Neglect, we know, is particularly challenging, and I think the way we measure it, it's kind of tricky. Is it an omission? Is it a commission? I've seen things deliberately withholding food versus not being helped with ADLs and IADLs. And then financial exploitation is also challenging. You've got stranger and family. And finally, the last session, we know this is a global forum, being sensitive to the wider cultural context. There's good work being done on promotores, community-based participatory research, and so forth. I will stop before I break the mics. Thank you very much.
And for time's sake, let's take a couple of quick questions, and I know the panel member will be able to write a white paper, and then later on in the day we'll be